All right, let's dive into a condition that's a true master of disguise, bipolar disorder. For millions of people, the journey to getting the right diagnosis is this long, winding, and really difficult road. And it often starts with just one simple but very misleading question.
For so many people, this is exactly where the story begins. They go looking for help because they feel this overwhelming depression, and that's often the only part of the illness that anyone sees, at least at first.
Just let that sink in for a second. 6 out of every 10 people who actually have bipolar disorder are told, nope, you just have depression. And why is that? Well, it's because for most people, the illness doesn't show up with a big dramatic high. It creeps in with the crushing low of a depressive episode.
A decade. That's the average amount of time a person waits for a correct diagnosis of bipolar disorder. A full 10 years of confusion, of struggle, and way too often of treatments that don't work, or, even worse, actually make things harder. So what happens during that lost decade?
Well, this isn't just some minor inconvenience. The stakes of this hidden illness are incredibly high, and the cost of that decade-long delay, it can be absolutely devastating.
A delayed diagnosis isn't just about waiting. It's a cascade of worsening outcomes. The risk of suicide skyrockets. We're talking 20 to 30 times higher than in the general population. And with every single untreated episode, the brain actually changes, making the illness more resistant to treatment down the line. All while patients might be taking medications that are basically just fanning the flames.
So to get the diagnosis right, we have to get past this really simplistic idea of just mood swings. We have to look at the entire full spectrum of the illness.
Okay, so on one end of the spectrum, you've got bipolar I. The absolute hallmark here is mania. And this isn't just feeling good, it's a state of such intense, elevated energy that it can lead to really impulsive decisions, feeling like you don't need to sleep, and sometimes even a break from reality. Just one episode like that is enough for this diagnosis.
And then there's bipolar II. Here, the pattern is different. It's one of major depressive episodes that alternate with what we call hypomanic episodes. Hypomania is basically a less severe form of mania. It's a definite up period, you feel great, but it doesn't cross that line into the severe impairment or psychosis that can happen with full-blown mania. So if a patient only ever talks about depression, how do clinicians play detective? Well, they look for clues, what are sometimes called bipolar validators. Things like, did the depression start really early, like before age 25? Is there a family history of similar issues? These are the kinds of red flags that start pointing away from just depression and towards a bipolar diagnosis.
One of the biggest clues can come from the treatment itself. As Dr. Roger McIntyre points out, if you give a standard antidepressant to someone with undiagnosed bipolar disorder, you can trigger what he calls the 4 A's. They get anxious, agitated, angry, and have problems with their attention. Instead of helping, the medication just makes everything worse.
Now, it's absolutely critical to understand that bipolar disorder doesn't just live in the brain. It is truly a whole-body illness, and it has these profound effects on your physical health. This right here is a crucial point. Bipolar disorder almost never travels alone. A full 90% of people with the condition have at least one other thing going on, from anxiety disorders to diabetes. So you see, it's not just a mental illness. It's more like the epicenter of this whole web of interconnected health problems.
And this is the sobering reality of that brain-body connection. The #1 cause of premature death for people with this illness isn't suicide. It's cardiovascular disease. Research actually shows they can have thicker arteries and a higher built-in risk for heart problems, which is linked to things like chronic inflammation.
So, given all this complexity, how do we treat it? Well, the cornerstone of treatment is a class of medications that we call mood stabilizers. The goal is to find the right balance, to kind of level out those extreme highs and lows. The mood stabilizer toolkit, it's really all about trade-offs. You've got lithium, the gold standard for preventing suicide, but it requires really careful blood monitoring. Then there's lamotrigine, which is fantastic for keeping depression away. Every single option has its own unique set of benefits and risks, which makes the choice a highly personal one.
Now here is a question that is incredibly important, but believe it or not, often gets missed, especially when a doctor is prescribing lamotrigine.
This is a critical interaction that can have huge consequences. The estrogen in most birth control pills can literally cut the levels of lamotrigine in your body in half. That can be enough to trigger a mood episode, and it goes both ways.
During the placebo week of the pill pack, lamotrigine levels can suddenly surge, which increases the risk of side effects.
The science of treatment is always evolving, and right now, we are smack in the middle of a major paradigm shift. And it's best illustrated by the changing fortunes of two of the oldest mood stabilizers out there.
Just consider this tale of two drugs. Valproate, which used to be a staple, is now facing heavy restrictions in Europe because of these alarming risks of birth defects, and those warnings now even extend to male patients. Meanwhile, Lithium, the oldest mood stabilizer in the book, is having a total renaissance. We have new research showing it can cut dementia risk by nearly half, and we figured out how to use it more safely than ever before.
But finding stability and, building a life, it's not just about finding the right pill. Medication is absolutely essential, but it's only one piece of a much, much larger puzzle. A truly effective long-term management plan has to be multifaceted. It starts with the right medication, for sure, but it has to be combined with psychotherapy to build coping skills, psychoeducation so patients and their families really understand the illness, and peer support to connect with other people who truly, truly get it.
This quote from a patient just perfectly captures the goal of treatment. It's not just about getting rid of symptoms. For this person, other medications felt like this constant internal battle, but the right treatment finally brought a sense of calm and control. It didn't just manage the illness, it turned the ignition off.
And that is the ultimate goal. We've moved so far past just stopping mania. Today, the real focus is on achieving genuine mood stability, preventing future episodes, and protecting the brain from the cumulative damage that this illness can cause over a lifetime.
And this brings us to the future. As our understanding of bipolar disorder gets deeper and deeper, moving beyond just brain chemistry into genetics, inflammation, the immune system, the possibilities for new treatments are just exploding. So the question for all of us is, what will that next generation of treatment actually look like? And how close are we to not just managing this illness, but truly healing the brain?